My name is Christian Bastian Talo, number 075. Okay, for the introduction, urological complications of renal transplantations are common and have some negative impacts on patients, both graft function, survivability, and morbidity. Complications as well as urethral stricture, urine leakage, symptomatic vesico-urethral reflux, urolithiasis, bladder outlet obstruction, urinary tract obstruction from lymphocyte are among the most common. Factors that have been linked with higher rates of overall urologic complications are including gender, especially male, delayed graft function, donor age more than 65-year-old, abnormal pre-transplant FCUG, repeatable transplantation, obesity, multiple donor arteries, and excessive removal of fat from donor ureter. Based on the problem above, we can form some objective about the paper. The first one is about to understand the normal anatomy, physiology of the urinary system, and the second one is to understand the overview about the renal transplantation, and the third is to understand the prevalence and risk factor of the urological complications in renal transplantation. The fourth is about to understand the overview about the urological complication in renal transplantation, and last, to understand the prevention of urological complications in renal transplantation. Thank you.
Hello everyone, my name is Putura Natalia Anggraini with student number 217. So today I will be discussing about the anatomy of the urinary system. So we have two kidney and they are located at the posterior wall of the abdomen or retroperitoneal. And each adult human kidney weighs about 150 grams and approximately the size of the clenched fist. And the renal artery and vein, lymphatic, nerve supply, and ureter, which deliver the final urine from kidney to bladder. Its storage in until the blood is stored is storage when it's stored until the bladder is emptied. All pass via the indented region of the medial side of each kidney called the hilum. And also, the vital internal parts of the kidney are protected by a thick fibrous capsule. Thank you.
Hello, my name is Christopher Minata, student number 153, and I will explain about the physiology of urinary system. So the detrusor muscle contracts and the internal and external urethral sphincters relax throughout the maturation process. Urine builds up and the bladder stretches the detrusor muscle, causing stretch receptors to be triggered. The visceral receptors carries a stretch feeling to the sacral region of the spinal cord, where it synapses with an interneuron that stimulates parasympathetic neurons while inhibiting sympathetic neurons. High bladder volume activates the pontine maturation center, which, as well as triggering awareness of a full bladder, results in internal sphincter relaxation and the decision to relax the external urethral sphincter when ready to void.
Hello, my name is Johanna Rena Benyamin with student number 150, and now I will explain about the overview of renal transplantation. Renal transplantation is the last option treatment and the indication is end-stage renal disease or ESRD. The aim is to increase the quality of patients' life and prolong their lives. Some research claim patients who have a renal transplantation have better long-term survival for over 10 years compared to patients who stay on dialysis. However, some patients with severe pulmonary or cardiac anomalies, active infection, active malignancies, uncontrolled psychiatric disorders, and active drug abuse should not receive a kidney transplant.
My name is Leonardo Albedias with relation number 120. Preparations before renal transplant. Okay, first patient selections. We should evaluate the patient using anamnesis, physical examination, or other supporting diagnosis to evaluate the patient to determine if the patient fit to the surgery or not. And second, donor selections. There are two. First, deceased donors. They are brain death and circulatory death. And for living donors, there are related, unrelated, altruistic donor.
Hello, my name is Putra Sebastian and my student number is 143. So I'm going to explain about the prevalence and risk factor of urological complication and renal transplantation. Urological complications are commonly seen in renal transplantation, with estimated incidence consists from 3.4 until 11.2%. With urolithiasis, lymphocyte, symptomatic physical-urethral reflux, urethral stricture, and urinary are the most common. Urological complications that's seen with the urethral stenosis are the most common of all. Male gender transplant function, elderly is provided transplant, the transplant physiology abnormality, obesity, multiple organ arteries, repeat transplant, and urethral height fat removal of provided transplants are the risk factors of urological complication. Moreover, bladder atrophy and post-transplant benign prostate hyperplasia conditions can increase risk of urological complication.
Hello, my name is Duko Pretna with student number 076 and I will explain about urethral obstructions. One of the most common complications of renal transplants is urethral obstructions. In post-operative periods, there's a chance about 1 to 4.5% recipient will develop urethral obstructions and most of them is distal obstructions. In another literature, the percentage of 2 to 10% of renal transplants have urethral obstructions within the first week to a year after the procedure. The etiology of this case dominantly, nearly 90%, started with devascularization of urethral that caused stricture along the line. This complication usually occurs during the first 3 months after the transplant surgery. Normally, renal recipient rarely develop any urethral obstructions unless there is ureterostomy and pyeloureterostomy while surgery to reconstruct the urinary tract obstructions. The other etiology that must be considered is malignant is in herbicide, especially when it's developed late after the transplantations. The populations of people who receive renal transplant are more likely to develop bladder carcinoma up to 3 times than average people. Management of this complication must be based on the proper diagnosis. To help clinicians to make a diagnosis, imaging modalities like ultrasonography, imaging, magnetic resonance or MRI, computerized tomography, and scintigraphy. After that, clinicians can proceed with the management for the patients. Managing the urethral obstructions depends on sort of things, including patient's conditions and preference of the clinicians. The considered gold standard for this case is open repair in urethral as it's more durable. The techniques itself are varied from based on the patient's needs, but mostly are ureteroneostomy, vesicopielostomy, ureteropielostomy, interposition of small bowel, and etc. When the gold standard cannot be performed, clinicians should be considered to use another managements like antegrade or retrograde balloon dilatations for minimally invasive therapy, urethral stenting, and positioning of bypass graft subcutaneous biological for the invasive one. That's all. Thank you.
My name is Dwi Notifa Depataraja with student number 136. Incidence of urinary fistula as a complication after renal transplantation is 1.2 to 8.9%. Clinical manifestation of this complication are delayed graft functions, decreased urine output, and increased renal output. The renal output in the postoperative period will be used to confirm the diagnosis by doing the creatinine and potassium laboratory tests. Integrated nephrostogram, contrast-enhanced CT scan, MRI, or radionuclide scan can be used to detect collocation and extravasation of urinary fistulas for optimal management. Management for low volume urine leaks is conservative by performing decompression, and management for large volume urine leaks or extensive extravasation or failed decompression is open surgical repair, which is urethral reimplantation with stent. Thank you.
My name is Indra Fasni Chavez with class region number 091 and I will be explaining about the vesical urethral reflux or VUR. VUR is the retrograde movement of the urine from the bladder to the upper urinary tract caused by a number of irregularities relating to the urethra's functional integrity, bladder dynamics, and the anatomic composition of the urethral vesical junction or UVJ. VUR has been linked to urinary tract infection or UTI, and this can cause renal scarring. And if this continues to happen, this will cause hypertension, pregnancy toxemia, and substantial renal damage, including end-stage renal disease. The clinical features that the majority of patients have are either asymptomatic or hydronephrosis or have pyelonephritis. The diagnosis can be done by using the gold standard of method by using voiding cystourethrogram or VCO. Vesical urethral reflux have 5 grading using the international grading system that can be monitored by VCO. There are 5 grades of vesico-ureteral reflux. The first grade is reflux only into the non-dilated ureter. The grade 2 is characterized by reflux into the ureter and the renal pelvis without dilation. And then grade 3 is characterized by reflux with mildly dilated ureter and calcicell system. The grade 4 is characterized by reflux to convoluted and moderately dilated ureter and renal fornices blunting. The papillary impression has not been lost. And also the last grade is the grade 5, which is characterized by reflux with a convoluted and highly dilated ureter, loss of papillary impression, dilatation of calluses with loss of fornices. And then the management that can be done for VUR is divided into 2 options. The first one is using medical management using active surveillance and antibiotic prophylaxis, and then there's surgical management using endoscopic therapy or open or laparoscopic robotic surgical procedures.
Hello, Dr. and friends. My name is Niluputu Saswata Syawida Putri, student number 224, and I will explain another common complications of renal transplant, which is urolithiasis. Urolithiasis is a term used to describe the condition where the stones that were formed in the renal exit through the renal pelvis and travel through the urinary tract, including the ureters, bladder, and urethra. Diagnosing urolithiasis can be done by laboratory examinations, such as urine analysis with microscopy, where you can possibly find gross blood or positive microscopic hematuria, positive or negative leukocyte esterase, nitrates, and white blood cell. In the urine, you can find HCG or CMP or CBC or lactic acid or amylase, lipase, and blood cultures if the patient shows symptoms of SARS. Imaging of urolithiasis can also be done by renal ultrasound, Doppler jet, X-ray, CT abdomen, or pelvis without contrast, and MRI. Assessment risk can be done by scoring the stone score to assess the risk of developing urolithiasis. Thank you.
Hello, my name is Isabel Priyatna with order number 115. So now we're going to talk about the lymphocell. Lymphocell formations post-kidney transplantations is a well-known complication occurring in 0.6 to 26% of patients. A lymphocell is a lymph-filled collection in the retroperitoneum that does not have an epithelial lining. The etiology of lymphocells remain unclear, but it is believed that it is caused by the transections of the lymphatic vessels accompanying external iliac vessels during transplantation surgery and subsequent lymph accumulations in a non-epithelialized cavity in the extraperitoneal plane adjacent to the transplanted kidney. Lymphocells are most commonly discovered by change during regular USG 2 weeks to 6 months following transplantations, with a peak incidence at 6 weeks. Lymphocells are frequently asymptomatic and are discovered by ultrasonography by change. Lymphocells usually go away on their own without the need of treatment. The severity of the symptom, the size of the lesions, probably post-operative consequences, and the patient's clinical conditions are all factors that can influence our treatment decisions. Percutaneous needle aspirations, continuous draining over time using various types of catheters, and also sclerotherapy with various drugs have all been recommended as a conservative treatment for post-transplant lymphocell. Thank you.
My name is Madigeni Risasatira and I am the last digit number 201. For the prevention of urological complications in renal transplantation, there are some methods that are said to be able to help prevent the complications from happening. The first one is ureteric stents, which are found to be able to reduce the incidence of urine leakage and ureteral stenosis. And a study has supported this statement by finding a rather higher rate incidence of complications in instilled patients with 6% compared to the standard patients with 1%. However, there are some studies that also found there weren't any associations between routine stenting with the rate of complications incidence. The second one is usage of lower dose of immunosuppressors, which has found to be able to help decrease the incidence rate of urological complications after introduction of new immunosuppressive regimens. And there's also a study that says performing ligations of lymphatic vessels in the patient during the procedure could help prevent lymphocell formation, as the complication itself could be originating from the transplanted organ. And by performing careful dissection and careful ligations, in all the lymphatic vessels in recipient iliac artery and vein could also help prevent the lymphocyte formation.
Hello, my name is Keturulan Radikatika Putri. My number is 010, and here I would like to conclude this paper. So this paper has given an overview regarding the anatomy and physiology of urinary stem that shows the most common surgical problems associated with kidney transplantations that are urologic in nature and that are related to the quality of the transplant, ureter, and the uterovesical anastomosis. And this paper furthermore has also underlined some of the most common complications such as ureteral obstructions, urinary fistulas, vesicoureteral reflux, and urolithiasis. And then therefore, to guarantee an optimal graft functions and survival, patients with this problem must be handled in a dedicated facility to help reduce the risk of urological complications in renal transplantations. Thank you.